He completed his medical degree at the Medical University of Innsbruck, specialized as a doctor of internal medicine, and then received his nephrology.
Can you see my slides?
Yes,
Oh, yeah.
perfect.
Perfect. Well, thank you very much for the kind invitation to give this talk, and of course for this anti-ALS GlomCon efforts and everything you're doing for the glomerular disease space with all the trainings. This is really amazing. So this topic is, of course, something I've been working on for the last 15 years, roughly. And I think this is a very timely topic, given what we have learned over the past couple of years. So these are my disclosures. And in today's agenda, I think we should focus on the potential mechanisms of action of rituximab in podocytopathies, then head over to a major part of this presentation that is talking about efficacy and what we have learned over the past couple of years, how effective rituximab is in minimal change disease and FSGS, and then providing an outlook what will happen over the past or the next couple of years in the space. So the learning objectives are clearly to name potential of target effects of rituximab besides mainly the CD20 depletion. Then review the efficacy estimates of rituximab in MCD, and the same for FSGS, and we should talk about primary FSGS here. And of course, name potential predictors of relapse in patients treated with rituximab. When talking about podocytopathies and rituximab efficacy, I feel this is a really incomplete field, like when you're visiting the Acropolis and you see a lot of missing pieces. So that's the same when I think about rituximab and podocytopathies. Etiology is very important, and I'm glad to see Shafak Mirioglu, who was the leading force here on the call today for this review we recently published in NDD. And as all of you know, FSGS and MCD are more like histopathologic lesions rather than disease entities. And we are coming back to that later on. Of course, we are talking about primary or immunological-driven FSGS cases. Then we have a lot of patients with undetermined causes, genetic FSGS, and a lot of different causes leading to secondary FSGS. And it's really hard to distinguish on the basis what we can see on the right-hand side, histopathology. Because if you perform a kidney biopsy, you will see these kind of lesions in different entities. So the Columbia classification is nice, but it's not really predictive of the cause relevant actually to lead on to FSGS lesions. I really loved last year when Marina Vivarelli and colleagues published this review on childhood nephrotic syndrome in the Lancet. And here on the left side, you can see this figure nicely displaying that MCD is mainly seen in the childhood space, and then it declines, while FSGS remains quite stable over time and increases in adulthood. And then on the right side, you also see that membranous nephropathy is gaining momentum. And we know that membranous is the leading cause of adult nephrotic syndrome. In a review we have published last year, we have tried to actually outline the differences and similarities of adults and children presenting with different forms of glomerular diseases. And here is just a snapshot of what we've done with minimal change disease and primary FSGS. And clearly you can see that the peak age here is in childhood in minimal change disease, while it's more or less in adulthood in primary FSGS. The clinical pathologic differences are clear in minimal change disease. We don't see significant lesions when we perform light microscopy, but on electron microscopy, we see this diffuse food process effacement. While in FSGS, and as we have already seen before in the Columbia classification, there are a couple of diseases-associated secondary forms leading to minimal change disease and also, of course, primary FSGS. And it's important to exclude this differential diagnosis before actually treating these patients with heavy immunosuppression, such as rituximab. Rituximab mode of actions is important to keep in mind that we are actually blocking or inhibiting CD20 positive cells. So we are actually here in the pre-B cell stage up to the early plasmablast stage. But what became more apparent recently is that in renal autoimmunity, we have this very strong plasma cell component in kidney diseases such as lupus erythematosus and so on, and that might explain why rituximab is a suboptimal drug in these diseases. It seems that for minimal change disease, for instance, the blockade of these cells is more relevant and does actually explain the high efficacy estimates, as I will show you later on. We have a couple of years ago published this NDD digest looking at the topic we are talking about, rituximab in minimal change disease and FSGS. And as a direct effect, of course, as all of you know, CD20 blockade is, of course, the mode of action of rituximab. But then a couple of years ago, a group from Miami actually published that rituximab is capable to stabilize the cytoskeleton, and we will come back to that on the next slide. On the right side, you see that we might actually be able to block or inhibit the soluble permeability factor, and we've learned about pathobiology of minimal change disease and of certain cases of FSGS a bit, and I'm coming back to that later. And then we have a couple of different T cell markers and also B cell markers, which can probably be inhibited by rituximab as well. And there was a lot of discussion that rituximab is indeed actually also blocking T cells within the immunological synapse. So this is the study from Miami, and it's published in 2011 by Alessia Fornoni. And you can see that if you look at SMPDL3B in glomerular structures, you can see in recurrent disease that there is a significant reduction of the mRNA signal. On the right side, you see this Western blot, and you see if you add rituximab here as a plus, here patient 1, 2, 3, 4, you can see the same picture. In recurrent disease without rituximab, you can see a significant reduction of SMPDL3B on the protein level, which has actually been mitigated when you add rituximab. On the lower pattern, you can also see actually the cytoskeleton and the stress fibers. And if you add on SMPDL3B here, recurrent sample is actually not capable to disrupt stress fibers. And this has been quantified here on the right side. If you overexpress SMPDL3B, this actually is pretty much maintained. This is unpublished data a couple of years ago, actually put together by Bani Gopaluni in Cambridge, when he was looking at lymph node biopsies of patients receiving rituximab for AAV. And what they have done here is to look at the peripheral blood, and you can see that CD20 cells, most of them are disappearing. So you only have, if you perform a really in-depth FACS analysis, you will see some CD19 positive cells after rituximab. But on the right side, if you look at lymph node tissue, you will see that rituximab is not capable actually to reduce tissue-bound CD19 cells in that extent. So roughly 10% of the initial CD19 cells are remaining in the tissue. And if you look at E&D biopsies, that even goes up to 35%. So rituximab is a suboptimal actually blocker of tissue-bound CD19 cells, which might be important when we discuss relapse risk and also refractory cases. So this was 2 years ago, and this is groundbreaking data showing that MCD in BARD is at least antibody-mediated disease, further underlying that rituximab use might be a rational strategy. So this is from Astrid Wine's lab from Boston, showing that 30% of her patients here actually tested positive for anti-nephrin antibodies. They used a threshold of 187, and this was based basically on the maximum diet in healthy individuals. They looked into the Neptune cohort and found that 11 out of 18 were positive initially. And you can see once these patients actually attained remission, the anti-nephrin antibodies went down, and this argues that these antibodies play a critical role actually in propagating the disease MCD. They found that if you look at immunofluorescence, you can see this bank date IgG is standing for IgG, as you can see here. And they have argued for a couple of years that this is basically what anti-nephrin antibodies do look like when they bind towards their structures in the glomerula. And then they came up with patient data, and this is a clinical course of a patient with childhood onset steroid-dependent MCD that progressed to ESKD with subsequent biopsy showing FSGS. And you can see here that the patient actually had an improvement of serum creatinine or UPCR after transplantation, but then actually had an increase and a recurrence of disease and received plasma exchange, and then actually 2 doses of rituximab, and the UPCR went down significantly. And on the right side, you see basically the anti-nephrin antibody titers in such cases. So pre-transplantation, you see a sky-high anti-nephrin antibody, which actually subsequently was reduced after transplantation, especially after rituximab. So this argues that from a pathobiology standpoint, anti-nephrin antibodies might explain a percentage of patients with MCD, but also likely FSGS, further underlying that this is a continuum of disease. More recently, and this was published in, I think, this issue of Kidney International, a Japanese multi-center study with a very thorough workup, including genetic testing in all patients, including whole exome sequencing. And they identified out of over 20 patients, 8 patients with a genetic FSGS, as shown here. And then they had 14 patients with a non-genetic FSGS. Of these, 11 actually had a recurrence of disease. And you can see that these patients were pretty young, and the age of transplantation was also in their childhood years. You also can see that they had a lot of graft biopsies during follow-up, probably actually underlining how complicated these patients are sometimes to manage during long-term follow-up. What they found is, and they used a commercially available ELISA, and similar to Astrid Wien's group, actually identified a cutoff based on the highest value they measured in disease controls in healthy individuals. And so defined this threshold as 231 units per milliliter. And what they found is that in recurrence FSGS, these anti-nephrin antibodies were higher in comparison to those 3 patients actually with non-recurrent disease, and of course those patients with genetic FSGS. They performed further immunofluorescence investigations and found that there is an IgG deposition co-localized with nephrin, as has already been shown by Astrid Wien's group. And they also showed that there is an increased expression of these phosphorylating substances, actually, which are important to stabilize, restore podocyte food process architecture. So this actually brings to light that anti-nephrin antibodies and the subsequent changes are really relevant in the pathophysiology of MCD or FSGS as well. Already a couple of years ago, people from the Netherlands actually put together this really nice review in Nature Reviews Nephrology, and I think this is really underlining what we are talking about here. So this is basically a graph showing that there is a continuum of disease. If you have minimal change disease, you will have patients who are more steroid sensitive, and then you have actually a continuum over to collapsing variant of FSGS, which is usually pretty therapy resistant. And these patients often progress to end-stage kidney disease in a couple of years. And then if they have a primary cause, also they have a high risk of recurrence after they receive a kidney allograft. What does KDIGO tell us? So here we have different scenarios, of course. Initial therapy of patients. If you have no contraindications to glucocorticoids, you should go for glucocorticoids. If you have contraindications, I think rituximab is really far behind here, also with a question mark, and I will show you that there is exciting data which shows that you can use rituximab without steroids to induce remission. If you have frequently relapsing steroid-dependent minimal change disease, so frequent relapses are pretty uncommon in adults, it says that if you have no previous exposure to cyclophosphamide, you should use cyclophosphamide. And if you had previous cyclophosphamide exposure, they actually mention rituximab here as one of the options to manage your patients. And I hope in the following couple of minutes, I will convince you that rituximab should be upgraded by the update of KDIGO. So one of the most important studies we have so far in adults is here from France, looking at 17 patients with steroid-dependent minimal change disease. And out of the 17, 11 had a good response to treatment. And I'm just showing you here the 6 patients actually who relapsed during follow-up. But as you can see here, the number of relapses per year before and after rituximab was used significantly declined. And also the time to relapse actually was on average at least around 12 months after rituximab, and most patients could get off steroids, which is really important in this cohort. You can see the relapse rate here before and after rituximab, and also how the corticosteroid dose could be reduced significantly over time. This is a study from London, also showing the same picture, relapse frequency before rituximab, after rituximab, the number of relapses per patient actually before rituximab here in dark, and then in white actually after rituximab. And on the right side, that what we've seen in ANCA vasculitis, that some patients are developing hypogammaglobulinemia after rituximab. That doesn't seem to be the case when you use rituximab in patients with nephrotic syndrome. So the nephrotic syndrome per se is causing hypogamma, but then you can see that IgG levels are going up during follow-up. This is a study from Japan, small numbers, only 13 patients, showing that if you use rituximab then as a maintenance treatment, as you would expect, relapses could be reduced, and also the corticosteroid dose could be reduced. And this is probably the way to go to use repeated rituximab in patients with minimal change disease as well. This is a recent meta-analysis published in Clinical Kidney Journal. And of course, there is one caveat. It's usually retrospective and observational data they are using here. But look at the rate of complete response in these patients receiving rituximab. And this equals to over 90% here. And you can see that there are vast differences here. A study from France, actually including 41 patients, only showed 61%, but some studies here from Japan and other centers actually showed up to 100% complete remission in patients with minimal change disease. This is a more recent study actually from China using rituximab as the first-line therapy in order to avoid glucocorticoids. You can see the indication here. Some actually had significant comorbidities like diabetes or osteoporosis, and some patients actually refused to receive glucocorticoids. You can see that the mean proteinuria here was 6.4 grams per day, and patients probably had a primary cause because their albumin was 20.6 gram per liter on average. On the right side, you can see that most of these patients attained remission, so 5 patients complete remission, 2 patients partial remission, and only 2 patients were non-responders. Important is also to mention that the mode of therapy here was pretty interesting because most patients only received a single shot of rituximab at a low dose, considering that Chinese population has probably a lower BMI than most of us do have. And here you can see that the time to remission is within a couple of days usually, and even during a follow-up period of over 1 year, most patients didn't relapse. So this underlines that rituximab is a good strategy to be used as an alternative to glucocorticoids as a first-line treatment. What is happening, because we have no clinical data in adults so far, one is Rifirine's study, which is well on the way. In France, looking at rituximab as a primary treatment. So all these patients receive a kidney biopsy, then receive steroids, and if they achieve complete remission, there will be a progressive decrease of steroids within 4 weeks, and then they will be randomized to have a further decrease of steroids plus rituximab, or in the control arm, a progressive decrease of steroids as well. And they are looking at a relapse rate at 12 months as the primary endpoint. 49 patients in each arm are planned. And as mentioned, I think over 2/3 of the patients have been recruited already. What about childhood nephrotic syndrome? And I'm an adult nephrologist, I'm not treating kids, but importantly also here, rituximab is pretty much on the lower edge here when we have frequent relapses, or even if we have steroid-dependent nephrotic syndrome, mycophenolate mofetil is mentioned here before rituximab. There has been a landmark study from Japan already a decade ago by Kazuo Ichima and colleagues, recruiting 48 patients with nephrotic syndrome. 44 of them had minimal change disease, and the primary endpoint was relapse-free period. Most of these patients came into the trial with cyclosporin, and it's a really complicated trial because they looked at different endpoints. So one was treatment failure by week 13. The second major endpoint was treatment failure between weeks 13 and 53. But what you can see here is that if you look at relapse here on the left side, you can see that in the control arm, and those were patients actually who were weaned off cyclosporin, the relapse rate was pretty high, and the median time of relapse was 42 days. In comparison, if you use rituximab, so a couple of infusions at inclusion, you have a relapse-free survival of 211 days. On the right side, they have looked at patients without treatment failure, and that was defined as early relapse or FRNS, SDNS after 13 weeks. And you can see a similar signal so in favor of rituximab. So in kids, we have good evidence that rituximab is effective to achieve remission and also to maintain remission at least for 7 months. What are predictors of relapse? And this is again from children because we have much more data from them. So 43 children receiving rituximab, they are starting to rebleed before 5 months. You can see that the relapse risk is much higher in comparison to those who have a more delayed CD19 repletion. So 11 here in this group and 3 patients only in the other group. What is known in childhood nephrotic syndrome now about rituximab, and there is more data coming up. So 250 patients here from India, 127 with steroid dependence and 123 with steroid resistance. So these patients received equal or over 2 sequential courses of rituximab. And you can see the efficacy estimates. So relapse risk was significantly reduced, and you will see that on the next slide. But also importantly, looking at the adverse events, only 0.2 per person years of adverse events. And you can see that if you look at serious adverse events here in orange, the population tested, and in blue actually occurring serious adverse events, that was really not pronounced in patients receiving a rituximab. As promised, so here are the data for the first year of follow-up, and here for the last follow-up available. If you look at the relapse rate per person year before and after rituximab, you can see an almost 3-4 reduction of relapses, and you can see that steroids could be reduced by around 70%. If you look at the last follow-up, the same picture, so 82.5% reduced relapse risk in comparison to the period before rituximab, and the same was true for steroid dose reduction. Importantly, if you look at the last follow-up, and that was basically just one course of rituximab, you see that a lot of patients actually achieved to become to stay in remission actually during long-term follow-up. and there were infrequent relapses in another 40%. And those actually requiring other treatments or more rituximab were actually only a minority of around 20%. Another study looking at children, and this is a huge study, as you can see here, looking at different courses. And important for me is, as mentioned before, looking at the lowest IgG value and hypogammaglobulinemia. You can see that even if you give more courses of rituximab in patients with nephrotic syndrome, it will remain pretty much the same. So here, lowest IgG when you use only one course, 341, and 316 if you use 7 or more courses. And those patients with a very low IgG level, here defined as below 200 milligrams per deciliter, were only 10.7% when you receive one course and only 8.7% if you receive more courses. So rituximab seems to be much more or much less actually inducing hypogammaglobulinemia in patients with nephrotic syndrome. What is known from big populations, that's CURGN, and you can see that the remission probability after rituximab was especially high when patients were glucocorticoid sensitive. That also argues, of course, if you're steroid resistant, there must be something underlying explaining the steroid resistance, maybe a genetic cause of nephrotic syndrome. And that explains why only 31% actually achieved remission when you had a resistant minimal change population. Importantly, also, if you have patients with childhood onset disease, they were more likely to enter remission after rituximab. The same meta-analysis, but now looking at relapse rates after rituximab, and this is clearly impacted by a very diverse follow-up time. So most of these studies reported only 12 months. So these were actually the studies with a pretty low relapse risk, but then you have studies which reported a longer term follow-up. And then you can see that roughly 40%, 50% are relapsing during longer term follow-up. So overall here, 28% was reported by this meta-analysis. How does relapse prevention with further rituximab look like? So this is a study from China again, looking at a very low dose regimen, initially only 4 times 200 milligrams and then 200 milligrams every 6 months. And I don't want to stress that too much, but you can see if you actually mitigate recurrence of CD19 cells, you can also actually reduce the number of relapses during follow-up. Importantly, all these patients actually achieving complete remission and receiving repeated rituximab over time actually had sustained remission, so no relapses occurred in these populations. So it might be that in accordance with other diseases like AAV, we need to treat these patients for a longer period of time and then stop once after 2 years and see how patients are behaving afterwards. So what about kinetics? And this is a major study actually from Marina Vivarelli's group in Rome, where they looked at different subsets of B cells, and they have looked at 28 children receiving rituximab therapy. And you can see here the B cells recurring at 12 months, the transitional B cells. But what they found is that the most important marker predicting long-term remission is actually switched memory B cells, and that's a marker of normal B cell activation development in GCs. They've come up with this very nice figure on the left side, actually showing the percentage of switched memory B cells among all different B cells, and here on the lower panel actually showing the cutoff of cells, and the picture is pretty much the same. If these cells remain depleted at 9 months, you have a very good long-term outcome with a low relapse rate, as can be seen here in this black line in comparison to the dashed line, where you have a higher percentage and a higher total number of cells at 9 months. So this is a marker which probably can also be used in adult population if it's available in your center. What about predictors of relapse after rituximab use? Here again, our review. And I need to say that this is only data from childhood nephrotic syndrome. So we are really lacking here in adults. And you can see, as mentioned, switch memory B cells, IgM on the surface of T cells, age levels of memory B cells, all from Marina Vivarelli's group. Some from actually Singapore, showing that the more rituximab you're giving, the lower your relapse risk, and some other experimental markers. But we need to bring these markers actually also to adult nephrotic syndrome, test them in a well-defined population, and then also implement them in our clinical routine. So our proposal here was to upgrade rituximab based on the recent studies, and some of them which have been shown by myself now. So we would say that in patients with frequently relapsing steroid-dependent nephrotic syndrome to do minimal change disease, rituximab should be second-line therapy after glucocorticoids. And I think, as in other diseases, we should avoid cyclophosphamide as good as possible. What about mixed cohorts incorporating minimal change disease and FSGS? So this is a study from Dr. Cortazar from Boston. And you can see here that in minimal change disease, your response rate is, of course, better than in those with FSGS. And if you look at the complete remission rate, you can see the blue line here, FSGS. We only achieve complete remission in a really small proportion of patients with focal segmental glomerulosclerosis. What's ongoing here is the Turing trial that's led by Megan Griffith in London and Lisa Wilcox in Cambridge, who have achieved to recruit 129 patients with minimal change disease and FSGS. And they are looking into rituximab-treated patients. There are two different prednisolone tapering regimen which can be used by the investigators, and of course then look into follow-up and the relapse rate of patients once they receive treatment with rituximab or glucocorticoids plus tapering. Efficacy of rituximab in FSGS, as mentioned, has not been that great. So this is one of the really good studies published early in 2009, looking at resistant cases only. And you can see baseline proteinuria here was quite high with over 10 grams on average. And you can see on the right side the prior immunosuppressive regimen used here, and this was quite a lot. On the flip side, efficacy was really bad. So if you can look here at month 12, you can see that only 2 patients responded a bit to the treatment, but not satisfactory. This has been mainly confirmed in the largest study we have seen so far. This is an Italian multi-center study looking at 31 patients with FSGS. And you can see disease onset here, 37, first rituximab administration at 40 years. Proteinuria at baseline 7.2 and at the time of rituximab 5.2. Here are the inclusion criteria: prior immunosuppression, so 2 patients refused glucocorticoids. And you can see most patients were steroid dependent and some were steroid resistant. Looking at efficacy estimates, response was seen at 6 months by around 52% of the patients with complete remission in half of them. There have been a couple of patients excluded because they have been retreated with rituximab, and all 14 patients with a response had a response within the first 6 months of rituximab. Importantly, those patients with a lower proteinuria, that means those patients actually achieving some form of remission or response to treatment at 6 months, or initially were having a proteinuria below 5 grams per day. So looking at predictors, so proteinuria at the time of rituximab below 5 grams per day was the most striking predictor of rituximab response. And similarly, also those patients with steroid dependence in comparison to steroid resistance actually responded to treatment. But FSGS, as mentioned before, is much more diverse and complicated. As we know, we need to exclude most of these actually patients from these cohorts. And that's in reality sometimes difficult to really focus only on those with primary FSGS where secondary causes have been excluded. One of the examples is probably this study here, So it's a study from Torino, a well-known group, and they have reported 8 patients with what they called primary FSGS, but they were quite old with 64 years. Most of them actually had some form of comorbidities like diabetes, osteopenia. And you can see that also if you look at age here, you can see that the baseline creatinine was really deteriorated in most of these patients. And that's not a feature we are seeing in primary FSGS when they present initially. Response rate here was poor, so you can see that most of these patients didn't really achieve a benefit once they received rituximab, as none of these patients really achieved a complete response. And you can also see that creatinine deteriorated over the period of time. And this is, of course, a difficult thing because what we have talked about is that if you have widespread diffuse food process effacement of over 80%, this is likely primary FSGS. But here you can see from the Torino study that 2 patients at least had widespread podocyte FPE. And if you look on the right side, this is a study from the Mayo Clinic showing that in genetic forms of FSGS, you have a high percentage actually of diffuse FPE. So it's really difficult to distinguish primary and genetic cases on the basis of FPE only. What about adult FSGS? KDIGO recommends a lot of different things. So CNIs is very prominently discussed here. And then rituximab is mentioned somewhere here in the alternatives. So there are some interventions mentioned like ACTH without any evidence and very expensive, and we wouldn't necessarily use it actually in the FSGS space. And as mentioned, many questions remain. I will skip that in the interest of time. And there are more important and interesting approaches. So this is an approach where you use intensive B-cell depletion, same group from Torino, using 6 courses of or 6 doses of rituximab plus cyclophosphamide. Similarly, a combination therapy we are using in ANCA vasculitis. And here you can see the proteinuria trend actually improving over time and also creatinine improving over time. So this might also in those with very severe nephrotic syndrome to do FSGS be an option for patients actually presenting with a multi-resistant disease. We are coming up with this proposal. So second line treatment in FSGS, probably to do the data CNIs and then as an alternative to CNIs, rituximab, then MMF, and maybe cyclophosphamide in those with relapsing steroid-dependent disease. In steroid-resistant disease, as mentioned before, data is not that great, and we might go with CNIs or rituximab here as a second-line treatment. What about other B-cell depleters? So this is a study, again in children, looking at ofatumumab versus rituximab. Large study including 140 children with steroid-dependent nephrotic syndrome, and you can see first cited that there is no difference in efficacy estimate and relapse rate over time. So ofatumumab probably not better than rituximab. But, and everybody's talking about obinutuzumab, and here is a study, I think from Colombia with 10 patients with membranous nephropathy. You can see that most of these patients have failed rituximab before, and rituximab was used within the year before obinutuzumab. And you can see the UPCR course once obinutuzumab was actually introduced in these individuals, and there was a significant decline in proteinuria, with some of these patients actually achieving complete remission. So obinutuzumab in membranous nephropathy underway in the Majesty trial, looking at efficacy in comparison to tacrolimus. What about frequently relapsing steroid-dependent minimal change disease? And this is a very recent study from China. You can see that most patients were actually pretty much immunosuppression naive, so all of them received glucocorticoids. But you can see at the time of obinutuzumab, proteinuria was actually pretty high in most patients. For by very specific treatment targets like APOL1 antagonist. We have DRP C6 inhibitors, and so on and so on. So the future is really rich also for patients with FSGS and also with minimal change disease. I'm coming to an end. Rituximab is definitely a valuable treatment option in childhood onset nephrotic syndrome with steroid sensitivity and steroid resistance. Rituximab is a pretty good treatment option in adult minimal change disease with the reduction of glucocorticoid exposure and the rate of disease relapses. We now know with the antinephrin antibodies, there is also a biological rationale to use it. Rituximab use in FSGS is very limited thus far, but as mentioned, and we have this data from Italy, 50% will experience a response, especially those with steroid-dependent disease and those patients with a proteinuria at baseline below 5 grams. Rituximab is a safe option to use in childhood and on adult onset nephrotic syndrome, and the frequency of hypogammaglobulinemia is ways lower in comparison to AAV and other diseases. With that, I would like to thank you for attention, and I'm happy to take questions.